Our next speaker is Fabrizio Salvi from Bologna, Italy. Fabrizio is going to speak to us about hydrocephalus in neurodegenerative diseases.
I'm a neurologist, and this is my center called Il Bene. It's a center dedicated to rare neurological diseases and to neuroimmune disease. Today we talk about normal pressure hydrocephalus. This was the first review, the first clinical review in 2001. And this is really the first review dealing about all the aspects of NPH. We can divide in two categories. The first one is idiopathic normal pressure hydrocephalus. The second one is the form secondary to subarachnoid hemorrhage, or intraparenchymal hemorrhage, or trauma, or aneurysm, or infection, or chronic inflammatory condition, or other rare disease. So in this disease, in the idiopathic form, no sex or racial predilection was noted. And the disease in the classical form starts in the 6th and 7th decade of life. The clinical manifestation. This is a triad of disorder. The first one is psychomotor retardation and progressive and mental retardation. The second, gait and stiffness. And the third is a problem of urinary continence. These are associated with hydrocephalus and associated also with an enlargement of the normal pressure in the CSF. We have no papilledema, and the pressure, as I told you, the pressure is normal after lumbar puncture. This is the well-known triad. And you can start to follow the first disturbances is a gait abnormality. It's a spatial gait abnormality. It's a sort of a magnetic gait with the appearance of patient feet being stuck to the ground. The second very important characteristic is the short step with the feet outwardly rotated. This may be confused with the Parkinson's disease. And you see the patient, small step and a sort of magnetic under the feet. This is not rare in MS population. This is another patient. And this work is very characteristic of NPH. Cognitive impairment is characterized by loss of cortical and subcortical and frontal feature. The most important aspect is psychomotor slowing, apathy, and decreased attention and concentration. This is another patient. You see the depressed appearance, but is not feel depressed. This is the disease. The third one is urinary incontinence, and usually it is seen, we see in advanced stage of the disease. But we have to keep in mind that the triad is not always present at the same time. We will see the triad in the advanced stage of the disease, but not in the early one. This is important because the diagnosis may be very difficult in the early stage. Brain MRI show ventricular enlargement, but the important thing is the symmetrical involvement of the frontal and occipital and temporal lobes, the frontal and temporal ventricles. Ten years later, after the first review, we have no more change. After 10 years from the first review, we still have too much uncertainty regarding etiology, classification, and treatment. No one was clearly done about this. These are a few points that I outline in this disease. To date, no clinical picture diagnostic test has definitely teased out idiopathic normal pressure hydrocephalus from other dementia that present in the elderly, and the gold standard for diagnosis remain clinical improvement with CSF shunting. This is very important. We have no marker, specific marker for the disease. This is my comment, this mythical triad may be present also in advanced stage of MS, but usually it is not diagnosed as an independent syndrome. From the starting of my study, I found, I'll show you later, 14 patients. Is it possible that neurologists don't see this? Or put all together in MS clinical findings? It's not true. It's not unbelievable. The second point, even in patients with hydrocephalus and the clinical NPH syndrome, shunting may normalize the ventricular dilatation but not relieve symptoms. So, what we can suggest that the primary problem in NPH is not only in the CSF drainage. Third, Evans index revisited. Evans index is a ratio measuring the diameter between the ventricle and the lateral brain and the brain, and it is typically used for diagnosing NPH. Evans index must be greater than 0.3, but another paper in 2011 even tell us that Evans index is not an ideal method for estimating ventricular volume in an NPH patient, because Evans index value can vary significantly in a patient with NPH. The fourth is what the review paper of 2011 told us. The exact mechanism of how NPH develops is yet to be determined. The first point is NPH is one of the few causes of dementia that is potentially reversible. There is no effective medical treatment or drugs that can work in this field. Ventricular shunting is the only treatment that has been found to provide benefit. The efficacy ranges from 33% to 90%. But the Cochrane review stated that there is no evidence to indicate whether placement of a shunt is effective or not in the treatment of NPH. Is the big problem outside the brain? This is my comment. Okay, but we focused our attention on MS associated with the NPH. The two patients that I showed you before were affected also by MS. This is what I followed one patient of mine, and you see the diagnosis was MS. The plaque are inside the brain, and you see in 90 the progression of the ventricular enlargement over 5 years. And you see the temporal horn, how is increasing the time. This is our population of MS patients. 14 patients. This is the mean age of onset. The age of MS, you see, before they had MS, they had MPH, they had MS with a delayed, medium delayed of 9.4 years. Oh, this is very interesting. All patients were affected by progressive form and not relapsing remitting form. And there was no clear association with sex. All 14 patients had the McDonald criteria for MS, and echo-color Doppler show CCSVI, were positive for CCSVI. And MRI were positive for, were compatible for a diagnosis of MPH. We have 2 patients treated. The first one was a patient with isolated hydrocephalus that was submitted to ventricular peritoneal shunt, and after a few months he had multiple sclerosis after the shunt. So, and the second patient was a patient with MS, CSSY, and the normal pressure hydrocephalus that was submitted to PTA treatment. What we found, this is courtesy of Professor Maleti in Modena, what we found was a very bilateral thin jugular vein in this patient, and the second really characteristic feature was tortuosity of intracranial collateral veins in this patient. This was really the first time that we saw this pattern. Hypothesis. Normal pressure hydrocephalus, secondary or to MS or not, is associated with the CCSVI. This is an echo Doppler study where they say our results suggest that retrograde jugular venous flow may be associated with the development of idiopathic normal pressure hydrocephalus. And this is another paper of Bateman in 2008, where he said this chain together suggests the variation in superficial venous pressure may occur in normal pressure hydrocephalus. The sagittal sinus compliance as measured by the ABD was reduced by 50%. This is a picture where I'll show you the region drained by the deep cerebral vein. Those are the same that are involved in normal pressure hydrocephalus hyperintensity. These are the 2 papers by Zamboni et al. This is what we suppose. CCSY, multiple sclerosis, normal pressure hydrocephalus, and patients that have all these 3 problems. We want to go on, and we prepare a protocol trying to estimate before and after the treatment of a PTA in patients with normal pressure hydrocephalus and MS. We want to do two groups. The first one associated, NPH associated with MS. The second, really idiopathic normal pressure hydrocephalus. And the primary endpoint is to verify the presence of CCSVI in both groups and to evaluate the safety and of PTA treatment in this patient if this patient had CCSVI. Thank you.